Good afternoon. This is Professor Amina Al-Deen with Muslim Network TV, and this program is Critical Talk. Today, we're back to talking about COVID, and we're adding the flu. All of us have questions, and the news, as usual, it's becoming a mainstay, is confusing as hell. So, what I've invited Dr. Ahmad Bastani was born in Iran, moved to the U.S. during grammar school, which was 5 minutes ago, and was raised in the uptown neighborhood of Chicago. He's a graduate of Rush Medical College and Northwestern University, St. Joseph Hospital, Family Medical Program. Career in academic medicine. Uh, I'm sorry, for about 28 years. I thought it was 29, but that's okay. It's 28. And he has a private practice in family medicine. I asked Dr. Bastani to lend us some of his wisdom because it's crazy out here and we need a sane, steady voice to get us back on track. So I'm going to welcome Dr. Bastani first. And what is the current COVID-19 situation? We're hearing a bunch of stuff, some matches, some doesn't. But tell us, what's the current situation with this COVID stuff?
Well, currently, thank you, Amina. Currently, what's going on is a very, very significant surge in cases. And it looks like there's a surge in the global numbers, as well as now that started maybe a month or so ago, and now over the last few weeks, it's really catching up in the United States as well. It's very sporadic, though. So there are portions of the country that are hotspots, Illinois being probably the number one area that's going up. And there are portions of the United States that are not surging, but definitely in a lot of urban areas in the Midwest, in the southern states, we're starting to see very, very steep increases in both the case rates as well as mortality.
Can you make that, a little bit longer? So it looks like, where is this? Yeah,
So if we
July, yeah.
if we go back, so the graphs that I've put up are for both the national case numbers. That's the one that says CDC on top. Yeah, that one. So this one you can see the first kind of wave over here is April, May, when everything started. And then we most likely, because we didn't do the mitigation as well as we could have, saw another over July. And then as you can see, this is about October, and as from October, it's just skyrocketing. Now, there's a caveat in this, in that these numbers are super high. So the peak in May was about 4,000 cases or so. I'm sorry, that's for Illinois. This is for the United States, so I can't see the numbers on the side. But the peak here was much lower than it is now, right? But that's partially because we weren't testing as efficiently then. We didn't have as many tests, not as many people were getting tested. So this is a underestimate. And even back in April, May, the medical community was saying that the actual numbers are probably twice or three times the numbers we're seeing on the test results.
So are you also saying that when not enough testing is done, you can have folk who may or may not be asymptomatic, but they may actually have it and are spreading it, and we're not testing enough?
Right. If you remember back in the spring, one of the biggest controversies was the follow-up in testing. First,
Right.
the test that the CDC rolled out was inaccurate, and there was problems with the reagents. And then they got that fixed, and then a lot of private companies and a lot of universities started rolling out their own tests. But even then, the testing was sporadic. The testing that we see isn't ideal. Ideal testing would be a coordinated national program where you do random testing. You go into communities, you take 1 million people. Out of those 1 million people, you randomly test 1,000 of them to see what the prevalence is, to see what the amount of disease in the population is. The way we're testing is it's sporadic. So someone wants a test, they go and get tested. It's not based on a scientific model of testing the community. So all of the testing results, quite frankly, are very, very crippled in a way, in that they're not giving us absolute facts. They're just giving us hints and trends of what's going on.
So let me ask this. We're literally, in many ways, a nation of immigrants and a nation of crazy people. So we have folk coming from other countries bringing disease which has largely been eradicated here. When we test for COVID, are we withholding some of that for tests for TB, malaria, other things that people coming from densely, like safe India, high TB rate, right? But we have migrants coming from India. We have migrants coming from places that have viruses that we don't, we've kind of eradicated. Are they also? Well, this is not a conspiracy theory. It's a real question. Are they holding it?
No, the testing is completely different. COVID testing is completely different from tuberculosis testing, and quite frankly, as part of the immigration process, they do get screened for certain tests, especially for certain diseases, especially for those that are preventable, like hepatitis, HIV/AIDS, things of that nature. Tuberculosis is definitely one of them, and some preventable diseases as well. So they make sure that everyone is vaccinated for the things that we normally vaccinate for here. So no, that wouldn't be an issue.
Well, that's good. That allays some fears of what's coming next.
Go
ahead.
The issue with bringing a disease into a community is what we should have dealt with, back in February, March or so. If there's ever an epidemic or a pandemic, which means an epidemic that engulfs the entire globe, what localities, i.e. a country, a state, a city, whatever it might be, what that locality needs to do is, number one, stop the disease from entering. So you close the borders for a short time, and then you mitigate and test. So you test everyone that comes in. So the ideal situation would have been to test everyone, have the test available, which we of course did not, and then test everyone as they're coming in with a rapid test. That is, even a rapid test that's not 100% accurate gives you a huge advantage in halting the incoming virus. It's basically like war tactics. You have to kind of stop it at the border. You stop it at the border. The stuff that filters in, you can deal with. But if you stop the majority of it, it won't spread like wildfire the way it did.
That's awesome. So tell us, what is your best advice, since we're a resistant population to doing what anybody tells us to do, for daily life? How we're back in the house now, many of us. What's your best advice for our daily routine to make it a routine?
So what I can tell you what I tell my patients. What I tell patients when I have a chance to talk to them is to have them sit down for maybe 20, 30 minutes, look at their life, look at their routines, look at their tasks and their responsibilities, and kind of create a hierarchy. The hierarchy being, what is the most important to me? what things do I absolutely have to do, and what things are less important. The things that are absolutely necessary, I'm going to take a little bit more risk. The things that are not necessary, I'm going to take no risk. So enjoyment, seeing friends, hanging out, going to a restaurant, going to work out, things that are not absolutely necessary, don't do. Things that are very necessary, having to go to work, having to see someone to take care of them, an older person that needs, that really does not have access to anything else but you go in there, but you mitigate as much as possible. So you wear a mask and you wear an N95 mask. You wear gloves maybe, you wear glasses. You're really conscious about touching things, about coughing, about interacting with them, about touching skin, things of that nature. The more you do that, the more you're playing the odds as far as stopping the spread. So you look at the situation. Is it a high-risk situation? Yes. I'm going to go into it with full gear. For example, today when I had to see a COVID patient in the hospital, I wear a mask, I wear shoes, dressing shoes, I wear a gown, all of that. In the office, when they're not, sick, if someone's coming in for a routine checkup or a history and physical, I wear a mask and I may wear goggles and nothing else. So you have to kind of stratify the riskiness of the situation and kind of go into it with that in mind.
Oh, I love that. I'm going to put that into.
Yeah, the big thing is to just sit, relax your mind, be very calm, not be nervous, and to really even write it all down. Yeah, write it all down. Write down what things are very important to you, what things are high risk. And high risk is basically anytime you're indoors with a lot of human beings. That's it. That's like the simplistic way of looking at it. Something that you can remember. You don't have to get a PhD in epidemiology. If it's involving other humans and if it's indoors, it's going to be automatically higher risk. If it's outdoors, it's less risky. If it's outdoors without humans, i.e. walking around, going for exercise, things of that nature, it's totally safe.
But I was remembering that the first thing is to sit down, calm down.
Correct.
So you're not trying to jam everything to the top of that hierarchy. Oh, I must do this, I must do that.
Yeah, one of the things that I emphasize over and over and over is, hunkering down like this has benefits as far as the spread of COVID. It also has negatives in all kinds of ways, social parameters. And the biggest negative is that depression, anxiety, boredom,
Absolutely.
psychological effects just go through the roof. And the longer it lasts, the more severe those things will be. So what I try to advise my patients the most is to really just work on the psychological aspect, because that comes first. That's where you start making decisions. So if you're in an anxious state, you're going to make anxious decisions. If you're in a depressed state, you're going to make depressed decisions. Relatively healthy state, you'll make better decisions.
That is very, very. I'm thinking about it as you're saying it, and sitting at home, you get anxious. I've learned to stop watching the news, and I can tell that my blood pressure is creeping up every time I see your president. So I turn it off real quick and sit back and try to chill. When everybody is at the point now. I was reading this article in Lancet that was talking about the number of mental health issues that are coming from people who supposedly have recovered from COVID, but all the rest of us too. We just haven't been treated for the many mental ailments that have seeped in, as all of the vagaries of life go on, parents, kids, loved ones, relatives, all of that other stuff is going on. So we all have a degree of anxiety. But when do I call you?
What I would advise is to call the doctor anytime you don't know the answer to a question as far as this is concerned. Not because doctors are all knowing, but because we just have a better understanding of the medical and to some extent the social aspect of this and the psychological aspect of it. So if you have a physician or a healthcare practitioner trust, and that's kind of the main word in this.
It
It
is.
has to be it has to be someone that you trust has your best interest in mind and is not going crazy themselves and trying to dodge questions. That person is going to have a little bit better access to good information, right? Right now, in the general public, I feel really horrible for people because they're really being bombarded by just so many divergent views, so many political views, and the political views are entering the medical world, and the medical um, response to it is never as big because we don't have access to the media the way the political world does. So there's just a
Say a
lot.
little bit more about that, because I don't think the audience, and I certainly don't know how the political chaos affects you guys.
Well, I can say it affects us in a few ways. I've been in medicine for 30 plus years now, and I've never, ever second guessed information coming out of the CDC. The CDC is the premier epidemiology infectious disease organization on the planet. Every other CDC, every other um, disease prevention type organization is modeled on the CDC. Anytime there's an epidemic or outbreak of this or that infection, the CDC is asked to go out and give them advice. This is the first year in my life that I've seen the CDC overcome by politics. And I don't know if you know, but quite a few hundred staff of the CDC were let go. I think 2 years ago or 3 years ago, very early on in the current administration. And then now in the last year, there's been just so much tweaking with what the CDC wants to put out and what it does. That
are they going to recover in a new administration that leaves them alone?
Leaves them alone and builds it back up. They have to get a lot of their staffing back up to par and have some assurance that political dialogues don't infiltrate as much. I mean, there's always going to be politics. It's a governmental agency, so there's always going to be some level of politics. But the current state is really untenable.
Well, I know that.
Even,
Go ahead.
Because even doctors don't believe anymore.
Well, I think some of us had heard of the CDC and were confused when you had a non-physician, non-scientist named Donald Trump going to override what they had to say. And I'm saying, what the hell is it? It's like being in a fantasy dream or, one of those science fiction movies or something. But I want to go back to this. I know this may be redundant, but what is COVID? How dangerous is it? We see the number of cases rising, but we also see a decrease, comparatively in the number of deaths. Are we learning how to treat it better?
So there's probably two factors that are affecting that. The first factor is yes, we are absolutely getting much better at treating, in my opinion. We're number one, not doing things that were probably harmful in the beginning, i.e., intubating everyone that fit the intubation criteria of other diseases until we found out, mostly by investigations of the Italian medical community that the type of pulmonary infection and the type of what's called ARDS, where the lungs kind of white out with fluid, it looks similar on chest x-ray, but it behaves differently with COVID. And in the COVID situation, it seems that ventilation, putting people on ventilators, does not help them in the same way that classic ARDS responds to ventilation treatment, that ventilation might actually harm them. So now what we're doing is really slow walking patients as far as getting them into a ventilator, putting them on ventilators. We're manipulating more with non-invasive types of addressing their low oxygen levels or hypoxemia. That's helped, in my opinion, it's helped people do better. Secondly, we're understanding better what this disease is. You know, COVID is quite different from most of the infectious diseases I've seen in my life. I grew up during the time of the HIV epidemic, and that was a learning experience. And as we went along and had more experience, we did more studies, we did more trials, we became more intelligent about how to approach it. I'll tell you, that process took years to get to a level where we were able to treat HIV with really good.
Yeah. That's true. Well, go ahead.
Yeah, in this situation, it's going much faster. So the issue with ventilators is a big one. We're finding out that with a lot of the very sick patients, steroids are key in helping them get through it. And then thirdly, we're finding that a lot of the complications and mortality of COVID is due to coagulation problems that it triggers. And now
that means the blood clumping, right?
Correct. Most immunological diseases, infections, trigger some part of the clotting system of the body. Most of them do not do it to a great extent. COVID, a small number of people, just makes the inflammatory markers go through the roof. And because there are all these different chemicals entering and causing coagulation disorders, people get blood clots. So they get blood clots in their veins, they get it in their heart, they get it in the brain, they get it all over the place. So now that we've learned that, we know to keep our eyes out and start treating the coagulation problem very early as things get bad. Once the patient starts getting very sick, we can start anticoagulation type medications to help them get through that aspect of the disease.
Awesome. Well, we're going to take a quick little break. You can drink your water. You can drink your water while you're talking to me, or you can have some coffee or tea, and we'll be right back. I want to explore some more stuff about chronic illnesses at this time, and the relationship between COVID, which is a kind of flu, like a super flu on marijuana or steroids, one or the other. And we'll be right back. This is Professor Al-Deen from Muslim Network TV with Critical Talk.
Billboards are popping up all over the country with an...
Our neighbors don't realize that Muslims are absolutely opposed to ISIS.
Salam. My name is Abdul Malik Mujahid. I'm an Imam in Chicago.
60 shots! No me! No justice! No me!
So how do we bring up the energy which can really have an impact on the world? You need to build bridges of understanding among people, and we need to have America moving forward.
That lesson learned have brought the strength of humanity to America, which is the diversity.
Mujahid Talks, only on Muslim Network TV. Faithfully connected.
This is Al-Deen with Critical Talk, and we are exploring COVID. I wish that were, it's probably going to be, they should name it COVID-20 by now. But anyway, the flu, chronic conditions and flu shot. One of the things is I just got my flu shot. First question, am I getting flu shot plus? You know, what the hell is that? And who tested that? When did that get tested? Or are people trying to use it as a marketing ploy? What's going on with that?
Are you talking about the senior dose
Yeah,
influenza
what's
vaccine?
the senior dose? I thought seniors got pneumococcal injections when they needed them. I'm just wondering, like what is fluff and what is real?
Okay, so influenza, the influenza vaccine is something that is quite variable. There are quite a few different vaccinations out there. Some of them are trivalent, some of them are quadrivalent, and now there's the kind of what they call a double dose flu vaccine. Basically, all it is it has a heightened level of the antigens or the proteins that trigger your immune response to protect you against the flu. And that's because as we get older, our immune system quiets down, it gets weaker. So by increasing the amount of the proteins that will trigger the immune system, you're hoping to reach the immune system of older folks, which is a little bit weaker, if that makes sense.
But what does that make sense? But what does that do? If my immune system is quiet and she's nice and happy, and I poke her twice with like giving her some espresso instead of her normal caffeine, what are the other possibilities?
There's no problems with it, if that's what you're wondering. The only problem with the senior dose or the double dose flu vaccine, in my opinion, is that it hasn't really been totally proven to be superior.
Okay.
It's probably safe as the old vaccine, and it's probably superior than the old vaccine. But it only came out, I think, a few years ago, so I'm still not 100%. I still think individuals over 65, it's probably a better idea to get the senior shot. But
I want to see you coming back.
Yeah, and the pneumonia shots, those are completely different. That's a completely different organism, and those you only get once. You get 2 different pneumonia shots.
Well, what is that? Is that what is it? Previn, whatever that thing is that starts with a P. They have all over the TV. If you're over 65, you should go get it.
That's Prevnar. That's a vaccine that we used to give just to children. And then they found out that it does give added benefit for seniors as well. So now we give Prevnar to seniors, as well as the old senior vaccine we used to give, which was called Pneumovax. They address different strains of the pneumococcal bacteria. So yeah, the strains that kids get are different than the strains that older folks get. So we had a vaccine for younger folks, and we had a vaccine for older folks. But now we're finding that the strains that typically hit younger kids are also somewhat prevalent in older folks. So we give both.
Oh,
yeah.
So now we got COVID running around, and it's flu season. If I get a cold, which I'm so hyped up now, I can't distinguish the cold from the flu, from COVID. They all run in the same family for me. What do I do? I mean, am I now more at risk of getting COVID because it's flu season, cold season?
You're more at risk of getting COVID because the numbers, i.e. the prevalence of the disease, is surging upwards in this area.
Okay.
It doesn't have anything to do with the flu virus. Okay, that's number one. Number two, the flu season this year, I'm predicting that it's going to be much milder than any flu season we've had.
Is that because COVID is the big dog on the porch?
It's because we're mitigating more. So that, wearing masks doesn't just protect you from COVID. It protects you from any respiratory disease.
Okay.
It's going to
Wow.
protect you from influenza.
So what about
But the second reason, that because of everything that's going on, I suspect that more people are going to do the right thing and get their flu shots. It's very important. It's not important to get the flu shot because it gives you protection against COVID. It's important for us because if we see a surge in COVID and at the same time we have a surge in influenza, that's going to overwhelm the healthcare system. You're putting all of this disease into the pot, in addition, a bunch of other disease. So, every year, tens of thousands of people die from influenza and hundreds of thousands are hospitalized. So anything you can do to limit the amount of disease entering into hospitals, i.e. limit the number of influenza patients and limit the number of COVID patients, or at least slow the spread of COVID so that the hospitals can deal with it, then you're positive. You're doing a good thing for society.
Well, when you, at the beginning of the show, you talked about the surge. Could you, for our audience, make the surge plain? People don't really, does that mean that hospital beds are again being appropriated, even though perhaps they've learned that you don't intubate every single person coming there? You're still quarantining them in some way. I know doctors are getting sick, nurses are getting sick, people are taking time off because they're of a mental health break, their nerves are getting bad. Tell us what the surge really means in plain talk.
Well, at its most basic, it just means that people are getting the disease faster and it's spreading wider than it was before. The problem with that isn't so much, it's partially we as a society, right? We need to be worried about the disease spreading because the more it spreads and the faster it spreads, the more people are going to get sick. They're going to have to lose their work. They're going to have financial costs. They're going to get hospitalized. Some of them are going to die. Some of them are not going to die and are going to have long-standing problems from COVID with some of the chronic diseases we're seeing. But there's another angle, and that's again saving the healthcare system. If you overwhelm the healthcare system, then you're really, really in deep trouble. Why? Because if the hospital is filled with influenza and COVID cases, number one, you can't take care of the regular cases. You can't take care of people that are coming in with chest pain, heart attacks, strokes, things like that. And secondly, the social drama or the social anxiety tells people, I'm not going to a hospital because there's COVID there.
Yeah, me. Don't send me for anything.
Yeah, I just had a patient who was sitting at home for a month with a cough, afraid to go to the doctors, afraid to go to the hospital because he didn't want to get COVID. And now he's in the ICU with a rip-roaring non-COVID associated pneumonia. So if he had made the correct decision, i.e. called his doctor and gotten the recommendation, he would have gone to the hospital or he would have gone to the doctors and gotten treated and everything would have been done. But because of the anxiety that's provoked, people are afraid to go. There's some interesting epidemiological numbers that are coming out that are saying that between April and I think July or August, the United States saw about 100 to 150,000 excess deaths. So deaths that were out of proportion with the same period last year. And the theory and what we think is happening is, number one, many of those were probably COVID deaths that were undiagnosed, but quite a number of them were heart attacks and strokes and things that were happening, and patients were just too afraid to seek medical care, so they just thought, well, I'll just ride it out. And that's the wrong decision. Hospitals right now are probably the most neurotic about mitigating and making sure that they don't pass viruses from one patient to another. Why? Because it's the place where most of the disease gets concentrated. Right? Anyone that's sick in the community that gets very sick has to be in the hospital. But they are meticulous about both cleaning and about mitigating, about isolating COVID patients in just one section of the hospital, having very, very strict rules about how to go in, how to come out of the room, etc. So people should not be afraid of going to the hospital, or if they are, they should not be afraid of picking up the phone and talking to their physician, because it should be a case by case basis. It's not, there's no general guidelines that we can give, i.e., if you get sick, what should you do? It's different in every situation. That's what's called triaging. So the best thing to do, again, is when you don't know the answer, call your physician or healthcare worker and get advice.
You know, one of the things in the literature that has come out in this last 9 months is the disparity in healthcare attention in minority communities, where people don't have good personal or any relationships with one physician, which I highly value, and they will probably highly value it too if it were available to them. So the only healthcare is these clinics, which in my opinion are mills, because they run people through there. So you know what I'm saying? You don't get settled on any one person that you can even begin the path of building trust.
Yeah, I think there's a mishmash of different qualities of health delivery in impoverished communities. There are clinics that are excellent. There are clinics that are not excellent. That, like you said, you see a different doctor every time. You don't ever have the opportunity to develop a personal relationship so that you can be you can have a trusting relationship with your physician. But another part of it is just distrust. A big part of it is, especially in the African American community, because they have a history of being wronged by the medical community going a few hundred years. So, and I think that still exists. So people are just cautious about trusting the advice that they get from medical, unless they have a good relationship.
Right. So, Doc, what about these vaccines? One day I turn on the news inadvertently because I really don't want to see the news until there's actually firmly a new president. But I turned it on anyway on my way to Judge Judy. And what I saw was Pfizer. Oh, we got a vaccine and it's ready to roll. And we got, I don't know, 3 million doses. And I'm saying, yeah, well, that wouldn't even take care of Chicago. But, I'm watching, it's this giving people information that is only a piece of the information. Then if you watch the BBC, you find out, well, whatever vaccine that is available has to be refrigerated X, Y, and Z, temperature below zero. Then you find out, or, if you, like you said, if I meditated and thought I would have known this, that who's going to get it? Well, first responders are going to get it in some places where they can store it.
Correct.
So why are they doing it?
No. So the vaccine situation, again, the problem with understanding what's going on with the vaccines is, again, that it's become so politicized.
Yeah.
That depending on the bias of whoever's delivering the information to you, you're going to get a very different picture. The reality of it, in my opinion, is that a functional vaccine, i.e., a vaccine that is at doctors' offices, hospitals, clinics, ready to go, and is able to reach a huge number of people, is nowhere near sight. If they can make that available, something like influenza vaccine. Influenza right now, the vaccine Everyone can get it. You order it, you get it, you give it. The supply lines are there, the manufacturing is there, the science is there. To get to that level, in my opinion, and I'm not an infectious disease specialist, but in my opinion, it's going to take at least a year. And that's given that we've been going so incredibly fast, which is amazing. But we have to understand that the prime candidates, the one that hit the news just a couple of days ago, that it's 90% or greater than 90% effective, that is an entirely new way of creating vaccines. And it's a method that we have never done before. So there's going to be a lot of unknowns, not just in the development of the vaccine, but a lot of unknowns in transportation and distribution, et cetera,
storage. So what they're actually doing is using first responders as another set of guinea pigs.
So I was one of the first people that got the first hepatitis B vaccines when they came out back in the 80s and 90s.
When you were younger and more risky.
Medical first responders, doctors, medical students, residents have always been good because to some extent it's appropriate, right? We know the most, so we'd be in a better position to take the risk of getting something novel or new than the average population. Yeah.
You all are courageous.
And on another level, it makes sense because we're going to be exposed far more than the average individual, right? So I come in contact with COVID patients almost on a daily basis, whereas you do not, or others that are staying home do not. So if you're going to stop an infection from spreading, you want to protect the areas where the infection has the greatest chance of spreading. So anytime a COVID person or a COVID patient meets another human being is that point. So if the medical community is the one that's going to see it the most, they should be vaccinated first. And then it would be the first responders like, excuse me, like paramedics, police officers, things of that nature. And then maybe the high-risk patients in the population. So people with obesity, diabetes, emphysema, asthma, smokers, et cetera, and then the general population. And that also gives you a better idea of how complex and complicated it is to get a brand new vaccine to the general population.
My immune system is quiet. Now you're going to shoot me up with something I don't know what it is. We have a question in the audience. What can you say to someone who refuses, you can see it on your screen, to wear a mask or thinks COVID-19 is just about politics, not about the reality of it?
Yeah. So you have to be very careful because if you approach them and tell them, to wear a mask, one option is that they will say, "Oh, okay, I will." The more likely option is that there will be a difficulty, right? And there could be a fight, or there could be an altercation, and that's a health issue as well. Right. So is it worth it? In my opinion, for the general population, it is not, unless you know the person and you feel like you can get a positive response from them. Not wearing a mask, again, is not the end of the world. It's the lesser intelligent of the two decisions, right? If you wear a mask, it's from a medical standpoint, it's smarter to wear a mask than it is not to wear a mask. Right. But not wearing a mask, if there's no COVID people around you, it's probably okay. And if you don't have COVID, it's probably okay. The whole public health push for wearing masks and isolating is basically based on numbers. We're dealing with statistics. The more people wear masks, the better. In the same vein, the more people get vaccinated for influenza, the better. If someone doesn't get vaccinated, if someone doesn't get vaccinated, it's going to create a hole in that strategy. If someone doesn't wear a mask, it's going to create a hole in that strategy. And quite frankly, we see now that in areas that are not on the team of wearing masks, those are the areas that have been kind of surging the most.
Hit hardest.
But I
Well,
would advise not to get upset, not to get mad, just kind of, stay away from that person.
but also now we're getting the other side where the people who refuse to wear masks want to attack the people who have masks on.
Yeah, those are all bad decisions. As counselors that work with at-risk adolescents say, life is merely a series of decisions. So the decisions you make have tiny little ramifications on an ongoing basis.
It is crazy. Well, one of the things that keeps popping up over and over and over again is shutting down versus conducting life as usual. How long, short of being in jail, which some people describe this as jail, who have never been in jail, but anyway, how long? I mean, how long can the psyche handle
Yeah.
not going out? Whatever life as usual is for that person.
The only advice I can give on that is that the key to success in any matter of life is resilience. We're in a situation that is not of our own. You have to. The way I look at this situation is literally as a war mentality, warlike or battle mentality. So you just hunker down on a psychological level and decide that you're going to be as tough as it takes. Yeah, the way it's gone is unimaginably difficult. It's difficult for me. It's difficult for everyone out there.
Right.
And it's difficult for different reasons. Everyone has been affected by this kind of closing up, opening up, closing up, opening up, wearing masks, not seeing your family members, etc., to different degrees. So the only advice I have is to just don't give in to depression, don't give in to anxiety, and just do your best. And if you can't keep up with it, it's not the end of the world. Just do your absolute best to make good decisions.
Well, I've got some information, but one thing I'm going to take and do when I stop talking to you is I'm going to this evening spend that sit down time and make that hierarchy, because I think that is a basic thing that all of us can do and to do our best. I want to thank you for spending. I know I hear your phone going off, and everybody's probably all ticked off at you because you're on here being glamorous, and they're over there frantic. But I want to thank you so very much for the time that you spent with us this afternoon with this really vital information and some advice that all of us can take heed to.